So there's actually a cheat sheet over there.
There it is. Hey.
Right? So carbon dioxide and water
Yeah.
form carbonic acid, right? And then that gets together with sodium and potassium hydroxide, right? And eventually all that releases sodium hydroxide and water, right? And calcium carbonate. And as this is occurring, and this is for soda lime, and you can see what happens with barrel lime down below, where it uses a little bit more water, and it also lets out more water. And these are both exothermic reactions, so you actually produce heat as you're absorbing the CO2, right? And so we actually use that to our benefit by lowering our gas flows so we can keep our patients warm throughout the anesthetic, especially for long cases. So how do we know when we've used up our CO2 absorber? Because it, pardon me? Turns purple. And what causes that?
That methyl violet.
Right, exactly. And so it's a pH indicator, right? So, basically it changes to, it's clear or white, right? And it turns purple or violet, I guess, as the pH of the absorbent decreases. So, can we rely just on that? Because I'm asking, you can't, right? So what else can we look at, or what should we look at to know that the CO2 absorber is done? FiCO2, right, so your inspired carbon dioxide amounts. So if you look at your CO2 tracing, your capnometer, you're going to actually see that your CO2 isn't going to go down to 0 during inspiration, and then that triggers you to look at your inspired CO2. And so you know to change it. So when we're changing our CO2 absorber, can we do it while the patient's asleep? Let's say we're using the Apollo. Right. So it's not the absorber, but it's the machine that determines whether you can do that or not. And the reason is because some machines will isolate the CO2 absorber, so you can actually change it so there's no leak in the system when you take out the CO2 absorber. But in the older machines where we're using this, I don't know if you've seen these, there's 2 stacked CO2 absorbers, so there's one down in this, and then there's another one here. With these, you actually have the gases going through during the ventilation, so you can't change the CO2 absorber if you're ventilating the patient. So what you would have to do is either to go apneic for a couple seconds while you're changing it. You usually should call for help. You shouldn't try and do it alone, just in case you get a leak. Or you have to be prepared, to put the patient on an ambu bag, start a propofol drip, which probably is an overkill, but just to make sure, because you won't be able to deliver any anesthetic agent through there, and change your absorber then. Okay, so because you can't isolate it. So if you look, they've actually come up with a really nice design of these absorbers, especially with the old machines, that this outer portion looks very similar to this. It has this elastic portion that gives you somewhat of a seal when you hook it back up. So some people think when they're changing the CO2 absorber, if it's loaded in here, the old one, you should just take this, keep that black portion, throw the rest of it out, including this. So you shouldn't do that, right? Because we found that in the trash, and the patient had a big leak when they finished changing the CO2 absorber. So you want to make sure that you're not throwing this outer portion away, that this fits inside the outer canister, and then you hook it up. So despite your best efforts, at times, because you're doing it on your own, this may not fit exactly, so you still could get a leak. So before you connect the circuit, just make sure you do a leak test, okay? Just so you know that it's properly aligned, okay? So just some things to think about. And then you can actually use the newer ones to your benefit at the end of the case. When you're trying to wake patients up, what you can do is go ahead and pop the CO2 absorber out, just like I have over here, right? Because when it's in, it's actually clicked in like this, right? So if you press this and it clicks out, you now have isolated the CO2 absorber, right? And the circuit's still intact. You don't have a leak there. So what you can do is at the end of the case, if you want to build up your CO2, pop this and build up your CO2, but your SIVO is still being scavenged, right? So you can continue to ventilate your patient, but have your CO2 rise slowly. And it might be one way to get your patient to wake up quicker.
Do you do that?
Pardon me?
Do you ever do that?
Very seldom,
Yeah.
but it's just because I'm not always in the room.
Right.
I do sometimes. So, but something to think about that you can utilize. So that's basically some of the things that you can do. How about in terms of the CO2 absorbers? Do we need to know what we're using and what happens with CO2 absorbers, and why are we concerned? What are the? It's not all that benign, right?
Some of the absorbers, so it can be the compound A byproduct, the SIVO.
Right. So it's when it's combined with a volatile agent, right? The CO2 absorber. So when is compound A produced?
Usually at low flows with sevoflurane.
Sevoflurane, exactly. So you get it more with sevoflurane at low flows, as you said, but it's with the soda lime or barrel lime, and barrel lime is more. It produces more, but the other is when the low flows are being used with the soda lime. Sorry, and with the new absorbents, the Absorb, you actually don't get the production of compound A. So they used to have a warning on the sevoflurane label saying that you should not use low flows when combined with soda lime, and they actually took that away when barrel lime came out. So you can use low flows and not have the problem of compound A production in low flow states. Okay, so there's actually a list of things that produce compound A, that increases the production of compound A. So low flow or closed circuit anesthetic has more of a production. If you're using higher concentrations of sevoflurane, you're going to get more of compound A production. When you use barrel lime, you're going to get more. The longer cases where when you have higher temperatures in your CO2 absorber, you're going to get more of compound A production. And so when you have barrel lime that's dehydrated, meaning desiccated, you have increased amounts. Okay, and with soda lime, you actually have decreased amounts of its production. Okay. So, what else do you produce that's toxic, that can be toxic with absorbers, besides carbon monoxide? Exactly. And so how would we detect carbon monoxide? What would you see in a patient? Is it going to affect your saturation? Yeah. So how low would it go? Would it go down to like the 80s?
the saturation
Pulse oximetry.
right away. Does it really?
It doesn't, right? So, and the reason is because when you get carbon monoxide poisoning, you get carboxyhemoglobin production. And the wavelength that the pulse oximetry is looking at does not detect that. It only looks at two wavelengths. It's looking at the oxygenated hemoglobin and the hemoglobin that's bound to carbon dioxide. So those two wavelengths are different from the carboxyhemoglobin's wavelength. And so you can't detect it. It might slightly drop down, but it's going to drop down from 100 to 96, not a significant amount. So it's not an easy way to detect with a pulse oximeter. So what else can you see instead? Think of in the ER, somebody comes in with carbon monoxide poisoning. What do they tell you? How do the patients look? Pardon me? Acidosis,
Yeah.
okay, all right, because there's no oxygen, right? So the carbon monoxide binds to the hemoglobin molecule a lot stronger, right, than oxygen does. And so there's more of carboxyhemoglobin there, and you get a cyanotic patient actually, right? But they don't look blue. So how do they look?
Cherry red mucous membranes.
Cherry red, actually, that's what they say, right? So they're hyperemic, right? Because they're not getting enough oxygen, they're vasodilated. And so you can't detect it by cyanosis, the cherry red color. Now, for the amounts that we have in the operating room, or we can get in the operating room, it's about 30% max, I would say. And you may or may not see this. The highest I've seen is like 10, and that was from a smoker, not because of this. They don't really look hyperemic necessarily at those amounts, but something to think about if you're getting high concentration. So at 30, I don't know, maybe you could get the hyperemia. The other thing that you can look out for is you could get some ST segment changes, right? You can get some tachycardia potentially from you have vasodilatation and you get tachycardia to compensate. But you could actually see ST segment depressions from just the cardiac ischemia. All right, so especially patients at risk who are older, coronary artery disease, you can see it in there. Okay. So what would be your actual diagnosis? How would you pick up carbon monoxide? How would you find carbon monoxide poisoning then? That you're producing carbon monoxide? What would be a way to detect it?
The machine can't detect it.
Pardon me?
The machine can't detect it.
The machine can't detect it, no, because the molecule size is pretty close to nitrogen, and so I think it's 23 carbon monoxide's molecular weight, so it's pretty similar to nitrogen, and it's not going to be exactly. So ABG tells you whether there's carbon monoxide, right? The level of carbon monoxide. We used to automatically get an amount that we saw in our blood gas readings, but nowadays it's all computer systems, so they're manually putting in some of these numbers, and unless you ask for it, they don't always tell you. So, and if it's abnormal, obviously they're going to tell you if it's high amounts, but the small changes, they're probably not going to tell you. So just something to think about. They'll send off ABGs if you're worried. So situations in which you get carbon monoxide.
What would make you worried?
So ST segment depressions, if you had, and no other explanation for it. And you want to look at factors that might cause carbon monoxide. You want to talk about that part?
Sure. So, it could, part of the reason that you could get carbon monoxide, or one of the factors, is also inhalation agents, but does anyone know which one would be more of a factor over, the 3 or 4 inhalation agents that you would use?
Which one would produce carbon monoxide more? Yeah, you can see it. You can
So
look over
yeah,
there.
it's also up here. So it would be does fluorine and fluorine, which we don't use here, but I don't know.
It's not available anymore.
Yeah. Isoflurane, halothane, and then sevoflurane is the least. So it's actually a little bit different than compound A, where sevoflurane is compound A. In this case, it would be the smallest factor as far as carbon monoxide. But also low flows, higher temperatures, and also the absorbent type. So bear lime, which isn't used anymore, and then of course soda lime. So at this institution, we don't. Bear lime isn't produced anymore, as I said, but we don't use soda lime. And we did use Draeger sorb for a while, and now we use Absorb. So both of these products are supposed to, there shouldn't be any byproducts made with these products. So there's no, I think the chemical makeup is a little different. There isn't potassium or sodium hydroxide. So in essence, you shouldn't be able to produce any byproducts or harmful byproducts. And also, if you can see, the Draeger sorb is all these small little, they look like pebbles, and the granules in here have a greater surface area, and so it reduces risk of channeling. So everyone know what channeling is. So instead of, there are problems with some of these where you wouldn't see the color change on the outside because it was going through the path of least resistance. So the inside could be all expired, and you do actually need to change this, but you wouldn't know judging by the color. That's why the color isn't necessarily a good indication of when it needs to be changed. So,
And in fact, Absorb, when it first came out with their product, they weren't as efficient with the absorption of CO2, so it was able to only do about, in terms of its efficiency, 40 to 60% of what soda lime and barrel lime did. And so part of the reason was because there was more channeling occurring. And there was also complaints that you couldn't see from the color. There wasn't a color change before you saw your CO2 rise, inspiratory CO2 rise, and that the reason was because it was channeling and you couldn't detect the color from the outside. So they actually came up with Absorb Plus, which addressed these issues. So the pellet size is a little different, and they made some changes so that it would be more efficient. So I believe it's about 80% now.
So in the past, when they would say you can't use, you shouldn't use sevoflurane with low flows, with this product you can. And even though this product is a little bit more expensive than other soda sorbs, it's supposed to offset the cost of the anesthetic gases, so you can have lower flows and the patient would be rebreathing, so you wouldn't have to use as much anesthetic agents. So that's the benefit to this. But if you're in another hospital where they're using different soda sorbs, you should just be aware of those differences and what your flows should be set at. And all that. So, is there any questions about CO2 absorbers?
Why does not using the absorbent for a couple of days increase the risk of carbon monoxide?
Because you usually have the machine on, there's oxygen that's flowing through, or gases that are flowing through, not necessarily volatile agents, but just air flowing through. And so what that does is dehydrates the absorber. And so they call it the Monday morning syndrome. And so you, because it's a desiccated absorber, there's more of compound A if you're using sevoflurane production and carbon monoxide production. So it's usually the dehydration that's the cause. So you don't have enough water molecules. So they recommend that you change your CO2 absorber when you come to a facility where the machine is on all night, especially in our trauma rooms. We leave the machines on, flows up usually, not intentionally, but they just leave them on because the last trauma case was using oxygen, so they just leave it on. So you want to make sure that you change your CO2 absorber, or an OB where we always have, we're ready to go with a crash C-section. They can dry up. So you want to make sure that you change it. They're actually pretty good about changing those. The techs are actually pretty on top of it, but if you find that there's a problem, you're worried about carbon monoxide poisoning, you're seeing some things that are not usual, that you can't really explain, think about it. There's also been some problems with airway fires with sevoflurane and Veroline combo, and that's one of the reasons they took the Veroline away, because there's a lot of heat production with low flows, and so they're not. If you find that a patient's getting really warm, let's say you're in a different facility, you don't know what they're using, and they happen to have Veroline, you can feel the absorber, it may be warm. Patient might show you signs of bronchospasm or some kind of airway irritation. They may be coughing. Their temperature might start going up faster than usual. All of those could be indicators that that there's heating in your circuit. And then one of the other ways to detect that is your dialed sevoflurane amount versus your inhaled sevoflurane is going to be different. So if you find that the patient's getting light, even though you're delivering large amounts, then you know that there's some warming going on, and you might actually have problems with your absorber. Okay, so you want to watch out for that. Before the time goes, that you have to go to another rotation, we should talk about the scavenging system.
So the scavenging system does what?
It takes volatiles out of the room, so we don't know everything with them.
Right. So we have an open system here. I would imagine that most facilities do. So there are several factors in which makes it an open system. One of which is if there is any sort of pressure buildup or a problem with scavenging, there's a way for everything to be released. And then also there's the most important factor, which is probably just the actual hooking up of the scavenging from the boom to the anesthesia machine. So there will usually be a short hose so that prevents any kinks or anything of that sort to happen, and then an adjustment knob so that you can adjust the scavenging. So this is on the Narcomed, the older machines, and so when this is hooked up to scavenging, this black ball should be between these two lines, and that means that you're getting the appropriate amount of scavenging, not too much, not too little. If it is above this line, then there's too much scavenging and you may get negative pressure. So your patient may not be getting the correct amount of anesthetic, and your anesthesia bag will be very decompressed, and it shouldn't be harmful to the patient. It won't necessarily be taking anything from the patient, but you won't be giving the appropriate amounts of anesthesia.